so much, sir. Continuing with our session, it is now my pleasure to invite Dr. Abhijeet Chaterjee, sir, a respected clinical and academician who have been actively contributed to internal medicine and cardio-biometabolic care. May I request Dr. Abhijeet Chaterjee, sir, to kindly take the stage and share his instincts with us.
Yes, sir.
This is your own topic. This is not my topic.
Nice.
I thank the organizers for giving me a wonderful opportunity to talk to the august audience. Varanasi is a center known for its learning since the early ages. And the topic on which I am going to talk is CRM syndrome, pathophysiology of the cardiac manifestations. As you see from this Venn diagram, there's an interplay between the metabolic risk factors, chronic kidney disease, and the cardiovascular system. The recognition of the interaction between the CRM diseases will enable a holistic approach to the CRM care rather than isolated treatment of the individual conditions. The nomenclature has changed progressively from 1988 to the present day. In 1988, it was known as the metabolic syndrome. In 2002, cardiometabolic syndrome. In 2022, cardiorenal syndrome. 2023, cardiac kidney metabolic syndrome. 2024, cardiorenal hepatic syndrome, which the organizers still maintain, but in 2025, it came to be known as the cardiorenal hepatic metabolic syndrome. The cardiorenal hepatic metabolic syndrome. There are 4 pillars. It is a multifaceted interaction of unified mechanisms creating a self-perpetuating cycle of multi-organ dysfunction. Chronic inflammation acts as the foundation, initiating tissue damage through the release of pro-inflammatory cytokines, immune activation, and fibrotic changes. Insulin resistance fuels this process, worsening metabolic dysfunction, hyperglycemia. Yeah, I thought I had 15 minutes. You know, I did not speak for 4 minutes. I think the timing is wrong. You started the clock before. Chronic inflammation acts as the foundation, initiating tissue damage through the release of pro-inflammatory cytokines, immune activation, and fibrotic changes. Insulin resistance fuels this process, worsening metabolic dysfunction, hyperglycemia, lipid dysregulation, which further strain the cardiovascular, renal, hepatic, and metabolic systems. As the condition progresses, oxidative stress amplifies the damage, increasing cellular injury, mitochondrial dysfunction, and reactive oxygen species production, thereby worsening organ failure. Finally, endothelial dysfunction closes the loop, impairing vascular integrity, increasing arterial stiffness, and perpetuating ischemic injury, which leads to additional cardiovascular disease, chronic kidney disease, hepatic fibrosis, and metabolic dysregulation. Together, these mechanisms create a cycle that drives the cardiorenal hepatic metabolic syndrome, making it a progressively challenging condition that requires a multi-targeted therapeutic approach. So the first of these pillars is inflammation, which is the foundation of the CRHM syndrome. The body regards obesity as a nuisance and tries to remove obesity with the help of meta-inflammation. It tries to break down the fat. There is low-grade inflammatory state, meta-inflammation. Adipose tissue expands, leading to hypoxia, cellular stress, adipocyte death. The pro-inflammatory M1 macrophages replace the anti-inflammatory macrophages. This disturbs metabolic homeostasis. The pro-inflammatory M1 macrophages secrete pro-inflammatory cytokines like tumor necrosis factor alpha and interleukin 6. These affect the insulin receptor signaling by activating serine kinases. The affect the phosphorylate, they phosphorylate the insulin receptor substrates and reduce glut-mediated glucose uptake. There is insulin resistance and hyperglycemia. The CD9 macrophages in obese adipose tissue cause inflammatory and profibrotic phenotypes. They cause systemic inflammation, cardiac remodeling, renal fibrosis, and hepatic steatosis. These inflammatory cells release reactive oxygen species, metalloporphyrides, and tumor growth factor beta. The second in the list is insulin resistance. This is the fuel for the CRHM syndrome. A crucial driver of the CRHM syndrome, it is a consequence and amplifier of chronic inflammation. The insulin-resistant states affect liver, muscles, and adipose tissue. They fail to respond to insulin, leading to hyperglycemia, dyslipidemia, metabolic stress, and multi-organ damage. Meta-inflammation in obesity alters the adipokine secretion. There is excessive free fatty acid release. These exacerbate insulin resistance, leading to lipid accumulation in non-adipose tissues like skeletal muscle and liver. These interfere with IR signaling. There are biochemical abnormalities such as elevated LDL cholesterol, triglycerides, and VLDL, and reduced HDL cholesterol. There is increased cardiovascular risk because of these alterations. Insulin resistance impairs lipoprotein lipase activity, reducing peripheral lipid clearance, hepatic overproduction of VLDL. There is accumulation of triglyceride-rich lipoproteins in the circulation. Impaired lipid storage in the adipose tissue leads to excessive circulating free fatty acids, which deposit in non-lipid organs such as liver, heart, and kidneys. They cause lipotoxicity and cell dysfunction. The third pillar is oxidative stress. It is both a consequence and reinforcer of the progression of CHRM syndrome. Under physiological conditions, the reactive oxygen species are neutralized by endogenous antioxidant systems such as superoxide dismutase, catalase, and glutathione peroxidase. However, in the CHRM syndrome, excessive production of ROS overwhelms the defenses. There is widespread oxidative damage to lipids, proteins, and DNA, leading to organ dysfunction. DNA damage is very important in the pathophysiology. It hinders cellular repair and regeneration in cardiovascular, renal, and metabolic diseases tissues. In the cardiovascular system, it leads to damage to cardiomyocytes, leading to heart failure, prevents LV reverse remodeling through repair. DNA damage markers are biomarkers which are associated with adverse prognosis and MACE. I'm going to discuss this later in my lecture. In the renal system, breaks in the double strands of DNA in the proximal renal tubular cells leads to weight loss, reduced fat mass, impaired glucose tolerance, mitochondrial dysfunction, and increased inflammation in the adipose tissues. Also, damage in the renal tubular epithelial cells, progressively leading to chronic kidney disease. Finally, in the list comes endothelial dysfunction. Nitric oxide is a vasodilator which is found in normal physiology. Suppression of endothelial nitric oxide activity in meta-inflammation leads to increased expression of adhesion molecules together with cytokine-induced phenotypic switching of endothelial cells. The mediators of inflammation cause shift of the endothelial cells from a quiescent to a pro-inflammatory and pro-thrombotic phenotype. Nitric oxide is a key vasodilator and anti-inflammatory molecule. These cytokines exhibit endothelial nitric oxide synthesis, expression, and activity, resulting in reduced nitric oxide bioavailability. The subsequent nitric oxide deficiency impairs flow-mediated dilatation and promotes vasoconstriction, increasing vascular tone and contributing to hypertension. Persistent hyperglycemia A hallmark of diabetes mellitus and insulin resistance initiates the Maillard reaction, leading to the formation of advanced glycation end products. The AGEs accumulate in the vascular and parenchymal tissues where they contribute to arterial stiffness, extracellular matrix remodeling, and atherosclerosis. These AGEs attach to their receptors known as receptors for AGE, RAGE, which trigger pro-inflammatory and pro-fibrotic signaling cascades, leading to fibrosis, activation of intracellular adhesion molecule and vascular cell adhesion molecule, E-selectin and PAI1. They lead to leukocyte adhesion, thrombosis, and microvascular injury. Friends, what is the use of understanding physiology if it does not help in patient management? So here we are from bench to bedside, showing how knowledge of basic sciences leads to better patient care. Advancement in biomarker research over the 2 decades has transformed the diagnosis and serial management of the CHRM syndrome. Traditional markers like lipid profile and blood glucose often miss subclinical organ damage, prompting a shift towards novel biomarkers. Recent studies highlight the significance of biomarkers associated with inflammation, endothelial dysfunction, fibrosis, and metabolic stress. Some of these have already been discussed by my previous speakers. I'll just make a bird's eye view. Early detection and risk stratification of CHRM syndrome is thus made possible. Number one is soluble urokinase plasminogen activated receptor, SUPAR. It has a role in chronic inflammation and immune activation. Use of this marker leads to early disease detection, risk stratification, and outcome prediction across both inpatient and outpatient care. It has potential therapeutic target. Number two, galectin-3. It plays a central role in chronic inflammation, fibrosis, and tissue remodeling. In heart failure with preserved ejection fraction, elevated levels of serum galectin-3 predict new onset disease, adverse outcomes, including all-cause death and cardiovascular death, and correlate with the severity of LV diastolic dysfunction and cardiac structural abnormalities. In CKD, it predicts all-cause mortality and disease progression. It also permits estimation of renal fibrosis and decline of the estimated GFR. In chronic liver disease, it is a marker for liver fibrosis and its progression. Galectin-3-like substance known as belapectin, these are currently under investigation for potential anti-fibrotic therapies in fatty liver disease. The other thing is growth differentiation factor 15. It is involved in inflammation, cellular stress responses, and energy metabolism. In the cardiovascular settings, GDF15 has robust prognostic value. It is an independent predictor of the all-cause and cardiovascular mortality, hospitalization, and renal dysfunction, and major adverse cardiovascular effects, mainly in patients with heart failure and atrial fibrillation. Serial assessment of GDF15 is valuable. The fourth one is the N-terminal pro-beta natriuretic peptide. Originally developed as a marker for heart failure, it predicts MACE, atrial fibrillation, heart failure, and renal complications, particularly in patients with type 2 diabetes. Albumin-creatinine ratio is a cornerstone marker in the integrated staging of CHRM syndrome. It reflects subclinical target organ damage across multiple systems. MicroRNAs regulate gene expression in cardiovascular and metabolic diseases. MicroRNA 423-5P mediates protective endothelial effects when overexpressed. It is downregulated in hypertension patients. Now, treatment. It is often found that people with the CRM syndrome, they are fond of eating When you give them food, they will say, give me some more, a little more, and they will go on eating till they are no more. So the first important thing is to counsel them regarding diet. Then physical activity. These will go a long way in the reduction of body weight. Then comes medication, which has been elegantly described by my previous speakers. I'll just make a bird's eye view. GLP-1 receptor agonists like semaglutide and liraglutide, they have comprehensive metabolic benefits. They reduce body weight, HbA1c, and MACE, particularly in patients with atherosclerotic cardiovascular disease. They have anti-inflammatory and hepatoprotective effects and are suitable for the treatment of fatty liver. Dual GIP receptor, GLP-1 receptor agonist, tirzepatide, they cause reduction of body weight, glycemia, and lipids, decrease fat content such as fibrosis-related markers like FGF21 and PRO3, suggesting a potential to reverse steatosis and early fibrosis, reduction in NT-proBNP and urinary albumin-creatinine ratio. The future consists of genomics, transcriptomics, proteomics, and metabolomics could uncover novel pathways and identify molecular signatures predictive of treatment response. And AI-driven health technologies will give rise to predictive models. Thank you.
Thank you, sir, for this detailed pathophysiological genesis of CRM syndrome. Which of these biomarkers can be used in day-to-day practice?
See, the biomarkers which I've shown you, they are mostly in the research state. NT-proBNP is already in use. Galectin-3 is available in some places. So these are entering the clinical arena, and I'm sure in the next 1 or 2 years we'll use them more extensively.
Any questions or comments from the audience? Thank you, sir.
Thank you very much.